Hello and welcome to another Saturday radiology session by Team RadioGyan. If I'm audible and visible on the stream, please drop a thumbs up in the chat so that way we know that there are no technical issues that we need to deal with. Standard disclaimer as always, whatever we discuss today, none of that is considered to be medical advice. This is for teaching and training purposes only. Our speaker today is Dr. Sameer Shamsuddin. He's been an FRCR teacher for almost 10 years now. He started the first FRCR 2B course in 2013, and he was the first in the country to successfully plan and deliver an online course and replicate an on-site courses in response to the COVID pandemic as well. He's currently a consultant MSK radiologist at Royal Lancaster Infirmary since 2012, and he's the founder of the website FRCRtutorials.com, which has been helping radiologists get accustomed to the exam, and he also runs FRCR courses via the same website. Additionally, he is also a member of multiple radiology organizations in the UK, and in fact, he's the founder member of the British Society of Emergency Radiology and helped them set up their organization back in 2015. Without wasting any further time, I would like to start our session as quickly as possible. Before that, I would like to thank Dr. Sandeep Awal for helping us with organizing this. Dr. Sandeep is a radiologist from India. He helps FRCR candidates via his Telegram group and website, radiologyvibes.com. So if you are interested in that, you can check out his website and sign up to their Telegram group where he shares cases and helps candidates with FRCR courses. Our three candidates today are Dr. Anil Kumar from Bangalore, Anish Thomas from Kerala, and Jarvis Pereira from Bombay. Thank you for agreeing to take up these mock exams. What we're going to try today is simulate the FRCR exam. The candidates will take up a few cases. While they are doing that, you can mentally, the viewers who are watching it live or even later can mentally take it up as you are giving the exam, and then go over the tips and tricks that Dr. Shamsuddin shares. For those who are watching it later, I will leave timestamps to everything in the description below, and I leave additional links, including to Dr. Sameer's website and resources. So make sure you check the description section and the timeline when you're watching it later. With that, too much of talking, I would like to stop so that we start our case discussion. Over to you, Dr. Shamsuddin and our candidates.
Thank you very much, Amar, for a lovely introduction, and lovely to have to be on RadioGyan. You've been doing a fantastic job. And thank you, Anil, for being the first candidate to go for the VIVA. So this is going to be just a straightforward VIVA, what you would expect in the FRCR 2B at Royal College of Radiologists. So shall we get started, Amar?
Yes.
Yes. Okay. So I'm just going to share screen in a second.
While these candidates are attempting the exam, the viewers who are watching live, you can type in your answers in the chat so that you are actively participating, and I'll keep a lookout at the chat as well.
Right. Anil, this is your first case. Are you able to see the cases?
Yes, sir. I can see, sir.
Okay. So this patient presented with shortness of breath.
Okay. I am looking at a chest radiograph of a skeletally mature patient who has presented with the shortness of breath. I can see abnormality at left hemithorax in the form of whale-like opacity with bulky left hilum. I can also see a loosened focus around the aortic knuckle, keeping with the lift shuttle sign. Apart from that, there is volume loss at the left hemithorax with diaphragmatic elevation and also hilar pull. So to summarize, there is an left hilar lesion which is causing left upper lobe collapse in a skeletally mature patient. I'm thinking of neoplastic etiology at first instance, and other possibilities like infective or mucus plug are less likely. This I am considering malignancy as my first differential. I'm looking for any secondary deposits in the lung or in the bones. I'm not seeing one. This is the case of left hilar malignancy with left upper lobe collapse. I convey these findings to the referring physician and like to like to take the case further by doing staging CT, thorax, abdomen, and pelvis. And also this case has to be discussed in lung MDT for further management.
Right, very well said, Anil. If you happen to report this case in an outpatient setting, so what will you do next? Like, how will you communicate the findings?
Yes, I immediately flag the report to the referring physician. This has to be, and this patient has to get CT, staging CT, thorax, abdomen, pelvis, not more than 2 weeks of duration. This has to be communicated to the MDT manager, lung cancer MDT manager, so as to fast track the CT and also MDT discussion.
Excellent, good. Okay, this patient presented with fall on outstretched hand.
Okay, this is the skeletally mature patient's hand, dorsipalmar view and oblique view, who presented with a fall on outstretched hand. I can see abnormality at the level of 4th and 5th metacarpophalangeal joints in the form of loss of alignment. I suspect there is a fracture dislocation at the same. So I suspect possible hamate fracture as the articulation.
You suspect or are you sure?
Yes, sir, I'm sure. I'm sure of fracture dislocation of the metacarpophalangeal joints at the 4th and 5th finger level. So this is an emergency. This has to be seen in a fracture clinic. So I convey findings to the referring physician, and this patient has to be seen in fracture clinic for management of the fracture dislocations.
Okay, very good. So let me bring up the next case. Okay, you can click on the image and scroll through the data set. This patient presented with shortness of breath.
Okay, I'm going through the axial images of a patient in lung window who presented with shortness of breath. I can see abnormalities in both the lungs in the form of multiple well-defined thin-walled cystic lesions of varying sizes. They are randomly distributed throughout both lung parenchyma. I can see mild effusion on left side. I'm going through the entire set of images. Yes. In my routine practice, I would look at the mediastinal window also.
Okay. If you keep your hands off the mouse for a second, please. Okay, so that's your mediastinal window. You can click back on the image and scroll through.
Yes, I can see left-sided pleural effusion. I'm looking at upper abdominal structures. Yeah, I can see mild dilated biliary radicals here. So apart from that, to summarize, this case of multiple cystic lung disease in a skeletally mature patient, female patient with multiple well-defined lucent thin-walled cysts of varying sizes with the pleural effusion. I suspect a possibility of first differential as lymphangioliomyomatosis, as this is associated with pleural effusion and also chylothorax. I'm not seeing any complications like pneumothorax in this patient. Apart from that, I suspect tuberous sclerosis complex in this lady. I would evaluate in line of the same. Apart from that, the differential diagnosis for the LAM is LCH, but I am not seeing any nodules or any history of smoking. I will correlate with the same. So to summarize, this is a case of lymphangioliomatosis in a skeletally mature patient with left-sided pleural effusion. So I convey these findings to the referring physician and discuss the case in lung MDT, and also like to evaluate in terms of tuberous sclerosis.
Not a lung cancer. So do you discuss non-lung cancer in lung MDT?
Lung MDT, non-cancer MDT.
MDT. Okay. Okay, right. Okay, so we'll come back to that later. So let me So just keep your hands off the
Yes.
mouse. Okay, this patient presented with acute drop in blood pressure. Okay, feel free to click on the image and scroll through.
Yes, sir. I am looking at axial images of contrast and CT abdomen, pelvis of a skeletally mature patient who presented with acute drop in blood pressure. I can see abnormality at the left kidney. So can I zoom the image, sir?
Of course you can. So just give me 1 second. Yeah,
Yes, sir.
feel free to click and scroll.
Thank you. I can see abnormality involving the left kidney in the form of large, well-defined soft tissue enhancing lesion. I am looking at the rest of the abdomen. I saw a few calculi, radiodense calculi in the gallbladder without any acute cholecystitis. I'm scrolling down through the pelvis. As I scroll down, I can see the abdominal aorta appears to be diffusely atheromatous. I consider this to be a case of possibly age-related disorder. As the patient presents with acute hypotension, I suspect some volume loss or any acute hemorrhage in this patient. I am not seeing any free fluid. So to see the acute extravasation of contrast, I would like to compare with the arterial, venous and delayed images. I am not seeing any contrast in the bowel loop or in the peritoneal cavity. As I scroll up again, I can see atherosclerotic. Yeah, I can see some occlusion of the left common iliac artery with mural thrombus and enhancement of the mural thrombus, keeping with penetrating ulcer. I am not seeing any acute complications like dissection here. I am again scrolling to the rest of the images.
Talk me through the kidney findings.
Yeah, this is a well-defined lesion with a hypodense non-enzyme scar with the rest of the kidney appearing normal. I consider possible differential to be oncocytoma in this case. So for that, I would like to compare with the previous image of the patient. If the lesion is of same size, same thing, it has to be considered oncocytoma and has to be required follow-up as this less like as this is as a characteristic central scar and spoke wheel appearance. And I saw abnormality in the left adrenal gland also, which appears bulky in size.
So these are all incidental findings, isn't it? So if you put everything together, what is the main finding that you should be worried about in an acute setting?
In an acute setting, maybe the thrombus in the left common iliac artery.
So what will you do next if you see a penetrating ulcer?
That will lead dissection, sir. That is an emergency.
So who will you inform?
I will immediately inform pick up the phone and inform the vascular surgeon and also intervention radiology on call for management of the case.
So what are the management options for penetrating ulcer?
Yeah, this can penetrating ulcer depending on the thickness of ulcer plaque. It can go to dissection, and this has to be managed with possible endovascular stenting. Yes, sir. And I will discuss the same with the vascular surgeon also.
Okay. No problem. So Amar, how are we doing with time? One more case.
Yes.
That's okay. This patient presented with hip pain.
Yes, sir. This is the frontal radiograph of pelvis, both hips, in a skeletally immature patient presented with hip pain. I can see abnormality in the left hip in the form of small size of the left femoral epiphysis compared to the right side. I can see mild, there is loss of clean line, which is there is mild medial displacement of the left femoral epiphysis compared to the right side. The clean line is not intersecting the 1/6 of the femoral head in this case. So for that, to confirm the same, I would like to get a frog leg view of the patient that shows clear medial displacement of the femoral epiphysis to the when compared to the metaphysis. So this has to be immediately managed by orthopedic, pediatric
Okay,
orthopedic.
so let me stop you for a second. So you mentioned about the Klein line. So you have the remote control with you. So I'm just going to try and draw the Klein's line here. So that is one of the signs. What are the other signs of slipped capital femoral epiphysis?
Yes, sir. Other sign is the uncovering of the medial portion of the epiphysis by the neck region here on the medial aspect. And other sign is volume loss. The femoral epiphysis appear apparently less volume compared to the right side.
Okay. In terms of management, so I am one of the orthopedic doctors,
Yes,
junior doctors in the ward, and my surgeon is not in station. So can I just reduce it and wait for him to operate tomorrow?
No, sir. There is a risk of vessels, which thin vessels which run through the neck to the head that may get injured. So that has to be immediately managed by pinning of the femoral head to the neck, and the opposite side of the hip also to be pinned, because the risk of epiphysis, slip
Or
epiphysis is there on the opposite side.
do you pin the other side routinely?
There is a risk of slipping on the other side also, sir.
Risk?
Yes, sir.
What is the risk? What is the percentage of incidence of bilateral SOFI?
I am not sure, sir.
Okay, no problem. Okay.
Dr. Shamshuddin, sorry to interrupt. Our time is up for the first, we have 15 minutes.
Okay, brilliant. Thank you very much. How did you think you did, Anil?
Don't know, sir.
I think you did very well. You did really well. You got through all the cases. I like the speed at which you are going. There are a few things that I would like to maybe pick on the cases, how you performed, and then we can go over those cases. Okay, so the first one is this one. I thought you were quite good in picking up the abnormality. You went straight into the slipped capital femoral epiphysis and described all the findings correctly. So I want you to pause between the sections of answers. Okay, so I find that you've been pretty monotonous in your answer, and examiner may not understand whether you are talking observation or you're talking management or you're. So just give a brief pause just for a couple of seconds.
Okay.
Like you can say that the frontal radiograph, both hips. So I'll just do this one for you. Okay, frontal radiograph, both hips, and I can see that there is a little bit of discrepancy in the height of the epiphysis on the left side, and there is metaphyseal extrusion sign with uncovering of the medial end of the epiphysis. Brief pause. In my normal practice, I would always look for a second review, which is a frog leg lateral and which confirms the presence of slip. Pause. And then in my normal practice, I would inform this urgently to the fracture clinic or the pediatric team, and the orthopedician needs to fix the SOFI in its current position because of risk of avascular necrosis, so that I don't have to ask you a question again. So if you fix it in the same, if you try to move it, then it will injure the blood vessels, so it can be fixed. Normally, routinely, you don't pin bilateral both sides at the same time. Only if it is symptomatic, they will pin. But they will definitely monitor the child. So if the child represents with the other side pain, then you can do an X-ray to confirm slip. Or if the patient is symptomatic and the patient has got a normal X-ray, you can do an MRI to look for pre-slip. So that is how you would do this condition. Okay, so just have a brief pauses between your sections and slow down slightly, not a lot. Okay, so you're doing really well. So next case that I showed you, I'll start from the beginning. The first one was a left upper lobe collapse. Again, the same thing, and you're using the words suspected a lot. When the abnormality is definite, you don't have to use the word suspect. Okay, so you can just go straight into the answer and demonstrate. You know your stuff, so you just have to put it through in the right phases. You did really well on this one. You described all the signs of left upper lobe collapse, and in the management, you would have to talk a little bit more. So I would just go through this case as I would do in the exam. So this is a frontal chest radiograph in an adult skeletally mature patient. I can see veil-like opacification in the left hemithorax plus an increased left hilar shadow, which is very suspicious of an underlying hilar mass. Okay, so compared to the right hilar, I should be able to see.
Dr. Shamsuddin, sorry to interrupt, but I think, is your screen sharing paused?
Not really. No, it is sharing.
Okay, sorry. No, sorry. Yeah.
Anil, can you see the screen?
Yes, sir. I can see, sir.
No, sorry. Yeah, it's you. I can see your screen. Sorry. Yeah, you can continue.
Okay. Yeah. So you have a left upper lobe collapse. When you come to the management, you would say that this patient needs a urgent 2-week wait referral to the respiratory team. So you will inform the respiratory lung cancer nurse practitioner. So flag the case to the respiratory lung cancer nurse practitioner and get the patient seen in the lung cancer clinic within 2-week time. Meanwhile, you will arrange for a staging CT of the thorax, abdomen, and pelvis with contrast and inform the GP or general practitioner to arrange for bloods to do EGFR so that they are okay for contrast, kind of a thing. Okay, so those are the couple of things. So that's very well done. So next case was this was again a straightforward case. So in the exam, you can get three patterns of cases. One is a straightforward case like a left upper lobe collapse or a slightly subtle fracture case. So these can come in the VIVA, so not just in the rapid reporting. So here you can see that there is a fracture and a dislocation at the base of the fifth metacarpal. This should be one of the review areas always. So you should always get a nice joint space like this in this, whereas here you have lost that joint space. So if you look at the hand radiographs, you should always find that one. Again, when you see A&E trauma radiographs, you can always say that this patient needs to be urgently fast-tracked to fracture clinic. Fracture clinic is the place where they will be seen. The third case, what was the third case I showed you? Lamb. So again, this one you did very well. You ran through, again, brief pauses between the section wasn't present. So it was a little bit hard to follow. So it was a very monotonous answer. So I would just brief it up. So don't be anxious while answering the question. Treat the examiner like they are junior doctors and you are giving an opinion. Okay. So again, you can see multiple cysts which are thin-walled and scattered diffusely throughout both lungs. And there is a little bit of pleural effusion on the left side. There is no evidence of pneumothorax. So you said all of that, so it was very good. And there is no nodularity and no loss of lung volume. So that is the key phrase. So whenever you talk about interstitial lung disease, you need to talk about lung volume, whether there is loss of lung volume or preservation of lung volume or increased lung volume. If the lung volume is not lost, then there are only few differential diagnoses like LAM, LCH, and maybe at the very most emphysematous bulle, you know. So rest of the interstitial lung disease have got loss of lung volume. So you say that there is no loss of lung volume, and this is a female patient in my, so the appearances are suggestive of lymphangioliomyomatosis, and this is part of a genetic condition called as tuberous sclerosis. So in my normal practice, I would get this patient completely screened for other signs of tuberous sclerosis. And then you can demonstrate your knowledge on tuberous sclerosis, saying if there is an old CT to compare with, I would look for any evidence of angiomyolipomas in the kidneys, and then any bone lesions. And then if there is a brain imaging, I would look for brain subependymal nodules. So, and if the patient is in the department, I could also go and look at the skin changes skin changes, Sjagren patches, and those kind of things. So this is how you will demonstrate your knowledge in the exam. Okay, so you did very well. So out of 8, you are scoring 6 and 7 in between. So that's still very good. Okay. So next case I showed you was, no, I didn't show you this one, 1005. This also we skipped, 1006. So this was brilliant. Not many people have answered this correctly when I have posted this to my students. So you are very right in picking up the abnormality, especially in the aorta. So there is a common iliac artery. So you can see that there is a penetrating ulcer with a thin rim. So that requires urgent interventional support. So you would inform your interventional colleagues and vascular teams. So potentially the patient will require stenting. Okay, stent graft for that patient. So that was very good. So Sophie, we have talked about. So overall, it's a good pass for you. So you're doing very well. So all the best.
Thank you, sir.
Do you have any questions? Quick one.
No, sir.
No, all clear. Good. Okay. Okay. Who have we got next?
We have Anish.
Yes, sir.
Hi, Anish.
Hi, sir.
How are you doing today?
Okay, sir.
Good, very good. Don't worry. So let's go to the next case. So this is a patient who was found to be collapsed in the street outside a pub. Okay, so I'm just going to give you a remote control. So you can click on the image and then scroll through the data set and tell me what's happening.
Okay, sir. Okay. These are non-contrast CT head of a patient found on the street. I can see bilateral hypodense extradural collections involving the frontal and parietal areas. I'm scrolling down. I am looking for any hyperdensity in the collections to look for any acute hemorrhage. I cannot see any acute hyperdense areas. I can see isodense areas in the collection. So my first diagnosis is bilateral subdural hemorrhage with it could be isodense hemorrhage.
So do you think this is acute or subacute?
If the patient's hematocrit is low, it could be acute. So I would check with the hemoglobin levels also.
So patient is in A&E at 2 a.m. in the morning.
Okay.
So, collapse. So the patient is, lab results will take time. So you have done a CT.
I can see that the ventricles appear to be mildly effaced. So this is acute. There is pressure effect on the brain. So this is acute.
That sign called as
Mickey Mouse sign. I'm not sure.
Yeah, rabbit eater sign or Mickey Mouse sign. That's good. So the patient has got bilateral subdural hematoma with mass effect. So what do you do next?
So I would immediately alert the on-call neurosurgeon because this patient requires surgical intervention to relieve the increased pressure. In my usual practice, I would look at the bone window also to look for any fractures if present. I'm looking at the posterior fossa. I don't see any abnormality in the posterior fossa, and the temporal lobes appear to be normal. The sella and suprasellar appears to be normal. I would immediately alert the on-call neurosurgeon for this. Patient might require a craniotomy to relieve the increase intracranial pressure.
Okay, good, very good. Okay, so the next case. this patient fell down the stairs. She's an 8-year-old lady. She had a bit of couple of glasses of wine and she couldn't balance herself and she fell down the stairs. So if you want to rotate the image, you can ask me to do that.
Yeah. Could you please rotate the image, sir? Like,
Okay.
This is a cervical spine radiograph of a lady who fell down. So I'm looking at the alignment. I can see a step at the level of.
Can you show me with your mouse?
Yes.
So click on the image and show me with your mouse.
Sir, can you see my mouse?
Yes, I can. Yeah.
Okay. 2, 3. At 3, 4 level, I can see an anterolisthus of C3 over C4 with. And I can see that there is a teardrop fracture in the antero-inferior aspect. So I'm suspecting a unifacetal dislocation because it is it's a grade 1 anterolisthus of C3 over C4, and I can see that there is a teardrop fracture at the antero-inferior aspect.
So is it flexion or an extension teardrop fracture?
I think it's a flexion teardrop fracture.
So how do you what happens in an extension teardrop fracture?
I think in an extension teardrop fracture, it's more posteriorly. I'm not sure, sir.
Okay, no problem. And which one is more serious, flexion or extension?
Flexion teardrop fracture is more serious.
Why is that?
Because it's associated with the cord, the spinal canal narrowing, and it could be detrimental to the spinal cord. So this patient, I would immediately convey my findings to the referring clinician and suggest immobilization of the neck with a collar, and advise, suggest an MRI of the cervical spine to look for any cord compression. I cannot see any fractures in the posterior elements.
So is there any abnormality in the posterior aspect of the spine?
I'm looking at the images to apart from the anterior slip, I cannot see any fractures.
Okay. What about the facet joints? You were talking about the unilateral facet joints. So is there any subluxation that you can see?
In this radiograph, I cannot appreciate any, but because of the anterolisthus, I'm suspecting unilateral unifacetal dislocation.
Okay. So what will you do next?
I would, if we can do an MRI immediately, I would suggest an MRI. Otherwise, a CT scan of the neck to look for facetal dislocation.
Okay, good. So we'll come back to that later. Okay, this girl is trying to conceive. So you've got 3 section axial, coronal, and sagittal images of the MRI gynecology pelvis. So basically, it's a infertility evaluation. Okay, so feel free to click on the image and scroll through the data sets.
Okay.
So you can choose whichever you want to start with.
Okay, sir. This is a T2 weighted axial image of a female patient trying to conceive. Looking at the images, I can see that there are 2 uterine horns with appears to be 2 cervical cervices. The frontal contour is convex. So, suspecting a uterine diadelphys.
So again, suspecting, or are you sure?
Okay, because the frontal contour is convex,
Three sequences, my friend.
Sorry, sir.
You have 3 sequences to look for.
Okay. These are coronal images. T2 weighted. So I can see two uterine horns. I'm looking at the sagittal images.
Mhm. Okay, you said you are suspecting uterine didelphys. Could that be a cause for infertility?
Because the frontal contour is convex, I am suspecting a bicornuate uterus. I want to retract my findings.
So what is the difference between bicornuate and didelphys?
In bicornuate, in didelphys, there will be two separate uterine horns and two cervix. In bicornuate bicolis, there will be two horns rather than two separate uteruses, like two uterine horns.
What about the cervix? How many cervix will be there in bicornuate?
In bicornuate bicolis, there could be a septum, cervical septum, which could divide the cervix into two. So,
okay, so it's okay. I think initially what you said was correct. You've got two separate endometrial cavity and then two separate cervices and two vagina as well. So that's uterine didelphys. So can these patients conceive normally, or is there any risk of infertility?
there can be difficulty to conceive, but they can conceive, but there can be increased incidences of miscarriages and other complications.
Okay, so the uterus wise, what are the other types of uterine anomaly?
Septate uterus, which is also carries increased risk of miscarriage. Then bicornuate uterus with rudimentary horn, when the horn is not communicating with the uterine cavity, which could present with hematocolpos in the rudimentary horn, and patient can present with abdominal pain and the hematocolpos because it's not communicating with the main the uterus.
Good. So what is the main problem with this patient? Is there any other thing that's going on?
Yes, because it's a Mullerian abnormality. I would look at the renal, any renal abnormalities is also there, and it could be associated with spine anomalies also. So I would suggest an ultrasound of the kidneys to look for any renal anomalies which could be present.
And anything else?
Spine anomalies can be present.
Okay, we'll come back to that in a minute. So how will you manage this patient?
I would convey my findings to the referring clinician, suggest a gynecological referral, also an ultrasound of the abdomen to look for the kidneys.
Okay. Is there anything else on this as a last question?
You can see the ovaries, they appear normal.
Okay, we'll come back to that later.
Dr. Shamshuddin, maybe we have like 1 minute for this candidate now.
Okay, so you can actually finish this case then. So, right. So in terms of ovaries, can you expand on what the ovaries look like?
Yeah, in T2 weighted images, I can see it hyperintense follicles.
So how many follicles normally exist?
Okay. It's multiple. It's more than 10. So it's
more than 10, and each one measures
less than 1 centimeter.
Okay, so what is the diagnosis?
Polycystic ovaries. Yeah.
Polycystic ovary. So how will you manage polycystic ovary?
Polycystic ovaries again can be difficult. There can be difficulty to conceive. Patient can be also menstrual irregularities can be present. We can maybe try to look at the LH-FSH ratio, which could be elevated.
Do you normally interpret LH-FSH ratio yourself?
No.
So where will you refer? So that's my
patient should be referred for gynecology for further management.
So which part of gynecology?
Infertility specialist.
Clinic. Yeah, infertility clinic, and endocrine assessment for the patient, and patient may require treatment for PCOS as primary cause for infertility. Good, very good. So how did you think it went today?
Oh, I was struggling with the case.
No, it's okay. I mean, I've been telling before, so we'll just do a review of your cases and also a bit of tips on how you can improvise. So as I mentioned before, there are 3 to 4 types of cases that you can get in the exam. So first one is a standard left upper lobe collapse or a fracture and things like that. And then the second one is a little bit more complex, but I don't expect you to come to nail the diagnosis. But what I would look for is how do you approach the case, and how do you look at the observation? How do you put things together and have a lateral thinking and guide the clinician into further management? And then the third pattern of case is I have no clue about this case. Again, the same thing. I would expect you to look at the case in a logical manner and talk through confidently. So I think you did well, and you would have passed today's VIVA if this was in the exam. So I wouldn't worry about your approach. In this particular case, you got a bit confused with bicoordinate versus didelphys. This is a case of didelphys. Among the uterine anomalies, all of them can conceive, so implantation is not affected, except in septate uterus where the implantation is a problem. But the problem with infertility is when someone says infertility as the main symptom, then conception doesn't happen. Are you with me? So it's not getting, they're not even getting pregnant. So the main organ that you need to look for is ovaries. So that's why I was asking, do you want anything else to look for? Do you want anything? So again, if this was ultrasound, probably you would have easily picked it up because it's a different modality. You are not used to seeing it. So in the exam, just apply the same principle. So multiple cysts less than 1 centimeter in size, more than 10 in number, and the ovary looks bulky and there's no dominant follicle. This is likely to represent polycystic ovarian disease. Patient will require to be thoroughly evaluated under infertility clinic. So don't talk about LHFSH USL because you're not a gynecologist. Okay, so in the exam, again, we want someone who will guide the patient in the right care. So not do everything for the patient. So patient needs to be referred to. If the patient does not come from gynecology, then she needs to be referred to an infertility clinic, and appropriate hormone assessment and treatment plan needs to be formulated. That's how I would do the case. So the next case was, what was the, I showed you purged facet and flexion teardrop fracture. So this patient, again, you are spot on and you picked the correct abnormality, which is the corner, anteroinferior corner of the C3 fracture. So this is a flexion teardrop fracture because the fracture fragment is much larger. Okay. So in an extension teardrop fracture also, the location is the same. It is not posterior, but it's a even further tiny fragment. Okay, in the extension teardrop fracture. In flexion teardrop fracture, it is more important and significant because it is often associated with posterior column injury, and that can be detrimental because although you don't see the ligamentous injury, patient would have had a ligamentous and cord injury. Therefore, you need to carefully look for any evidence of so if you see line here.
Yes.
Yeah. So if you draw lines along the facet joints, they should look like train track or parallel line sign, and you lost that at C2, C3. So that's a flexion teardrop fracture. And the next thing that you want to look for is widening of the interspinous distance. So if you look at the spinous process distance between each level, so this level is significantly widened. So that means there must be a cord and ligamentous injury. So this is a very severe injury. So you would inform the emergency department clinician saying that the patient has got a significant spine injury. Patient needs to be on cervical collar. So there is no collar in this patient. So patient needs to be put into collar and immediately referred for spinal team assessment and try and organize an MRI if possible to characterize the degree of injury. So that's how I would approach the case. And if you have any evidence of if you've got another view, if you're shown, you can always try and say which side it is deviated by looking at the spinous process. So you can see the spinous process there, you can see the spinous process here, whereas the spinous process is deviated to the left. So therefore this must be a left-sided facet joint dislocation. Okay, So any questions in this case?
No, sir.
No, clear. Okay. So the last case I showed you was this one. So many people struggle with this case. So it's not unusual for people to struggle with bilateral subdurals. And it can be hard at times to say whether it is acute or chronic. So always look at the sulci and gyri. And next thing you want to look for is interhemispheric fissure. So there is some thin layering of hyperdensity along the posterior interhemispheric fissure and basal cistern. So this is likely to represent acute or chronic subdural hematoma, usually chronic alcoholics. So in the clinical history, I mentioned about patient found unresponsive in front of a pub. That means he must be a drinker. Okay. So again, you can see the sulci are completely effaced at the vertex, and when you come to the level of the frontal horn of the lateral ventricle, they look like rabbit ears. Okay, and that means that there is significant pressure. So there is no sulci present here. All the gyri are crowded, and there is a widening of the interfrontal distance from distance between the frontal horns. So this patient is sinking. And in my normal practice, I would recommend an urgent referral to do neurosurgery for decompression. So that's how we would do this case. So you did 3 cases. In the exam, again, this can happen, but it just depends on what type of cases you get. It doesn't matter whether you have seen 3, 4, 5, or 7 cases. It's the average of the scores that you have done. As long as you have done the cases well, I think I'm happy with that. So overall, it's a good pass for you today. So well done.
Thank you.
Dr. Shamsuddin, before we move on to the next candidate, Junaida has requested in the chat to repeat the sign. What was the sign about midbrain that you talked about? Mickey Mouse ears?
Yeah, it's the Mickey Mouse sign or the rabbit ear sign. I call it as rabbit ear sign because if you compare it, if you look at a rabbit, it's got this ear, right? It's a widened ear. So frontal horn of the lateral ventricles should be much more closer than what you're seeing in this patient. So that's called as a rabbit ear sign. And the more subtle abnormality is crowding of the gyri with loss of sulci. So that should point towards intracranial mass effect.
Okay, thank you. And just before we move on, Dr. SR has asked if there is any pneumosyphilis.
I don't think so. What we are seeing is a bit of fat that we are seeing. So if you put the density there, it is more of a fat density, so that you can see it's less darker than the gas which is in the ear canal.
Okay, yeah. Thank you. And now we can move on to the next candidate.
Okay, no problem. So just give me 1 second. Hello, Jarvis.
Hi, sir.
Let me bring up your cases next. I won't be long, Jarvis. Just give me 1 second.
Sure, sir. No problem.
Okay, here we go. This patient presented with shortness of breath. And I'm just going to give you remote control. You don't need to do much with this radiograph.
Okay. I'm provided with a frontal radiograph of the chest of a skeletally mature patient. So the first abnormality that I can see is the evidence of a tubular structure extending from the right hilum below the diaphragm. So in my usual practice, I would compare with the with previous radiographs of the patient if present, as this kind of structure usually resembles that of a schemata. So I would compare with the previous radiographs and can correlate with the clinical history of the patient. And
okay. When clinical history is acute shortness of breath and dyspnea, and also patient has been coughing recently within the last 3 days.
So in based on the chest X-ray, there's also evidence of of mild opacification involving the right upper zone. So I would so if I would confer these findings to the chest physician and ask for a CT of the chest
What
to
type of
correlate these
CT would
findings,
you like to do with
and
this present
an HRCT chest.
HRCT? You talked about some vascular anomaly, so you don't want to
Yes.
give contrast?
No, a CT chest with contrast. Sorry.
Okay. Acute shortness of breath, sudden onset. So what type of CT would be best for this patient?
I would basically think of a CT pulmonary angiogram to rule out the possibility of a pulmonary embolus since the acute presentations.
Okay, so here is your CT pulmonary angiogram. So click on the image and you can scroll through the images. If you need to change windows, just ask me. Okay.
Okay. Okay, I'm provided with a CT pulmonary angiogram. The same patient. So on scrolling, I can see that I can confirm the presence of the vascular structure in the right hemithorax to be the schemata vein, as it is seen to be draining into the suprahepatic IVC.
Mm-hmm.
So
where does it connect?
And it appears to be.
So what is a scimitar abnormality?
It's a partial anomalous pulmonary vein, sir.
So what type of fistula is it?
It's a pulmonary to systemic fistula.
Pulmonary systemic fistula. Good. So why is this patient got acute onset of shortness of breath and dry cough?
I'm just trying to see the possibility of any filling defect, sir.
Okay.
But I'm having a problem with the scrolling actually.
Do you want me to scroll?
Yes, sir, please.
Okay, let go of the mouse so that
Yes.
both of us don't scroll together. So I'm going up now. And down. Okay. You want a lung window?
Yes, please. Okay, on the lung window, I can see evidence of ground glassing present in the predominantly in the right upper lobe and the lower lobe. So based on now, depending on the current scenario and seeing the presence of acute presentation of the patient in the presence of a pandemic, which is presently there, my primary differential would go in favor of a COVID-19. So COVID-19. So I would urgently call up the emergency team and ask to isolate the patient as soon as possible. So and do the necessary tests like an RT-PCR and a rapid antigen, and confirm my diagnosis. The other differentials for a ground glass with crazy paving pattern would also go in favor of other things like a pulmonary alveolar proteinosis, eosinophilic pneumonias, and all. So I would correlate these findings with the blood with a blood test done for the patient, and but in the present scenario, my primary differential would go in favor of a COVID-19 pneumonia.
So next case. Just give me 1 second.
Sure.
Yeah. So this patient presented with headache and also abdominal pain.
Okay, sir.
So you want to scroll or you're okay?
Yes, I think it's better if you scroll. Okay. I'm provided with CT non-contrast sequences of a patient who complains of headache and non-specific abdominal pain. So the first abnormality that comes to mind is the evidence of diffuse calcification, which I can see calcification as well as calcific nodules, predominantly lining the ependymal bilateral lateral ventricles. So these findings are usually classic for tuberous sclerosis. Other than that, I can also see calcification in bilateral cerebellar hemispheres. These calcifications could also be seen in Farr's disease due to the extensivity of the calcification, but predominantly due to the ependymal location of these calcific nodules, I would think of tuberous sclerosis as the first thing. So I would also like to do a ultrasound of the abdomen of the patient to see the kidneys, and if the patient is a known case, I would compare these findings with the previous images and see if there has been any change in the sizes of these nodules.
Okay, so here is a CT chest, abdomen, and pelvis for the same patient.
Okay, I'm provided with a contrast enhanced CT sequences of the chest and abdomen and pelvis. So the visualized, I can see I can see evidence of multiple fat-containing lesions in bilateral kidneys. Both the kidneys appear bulky in size. There's evidence of a contrast blush in the left kidney. So the contrast blush in the left kidney. So my primary suspicion would go in favor of my primary differential would go in favor of a rupture of the angiomyolipoma in the left kidney, which could be the cause of the patient's bleeding. There's also evidence of few gallbladder calculi and hypodense lesion in the liver, which could be a hepatic cyst.
Yeah. So what?
So the first, I would pick up the phone and contact the interventional radiologist and the vascular surgeon for embolization, for necessary embolization of this lesion, and
anything else? I've already told you in the lab for one of the patients with TS. What else can you do? Genetic screening for the
genetic screening for the rest of the family members as well.
Correct. Good. So just give me one more second.
Dr. Shamsuddin, I'm not sure of the exact time, but we may want to wrap up soon, if possible.
Sure. One more case, and we can go through this one. Okay, this patient presented with was playing football, and he was involved in a tackle. Okay. So
sir.
Professional footballer. I'm just scrolling from medial to lateral.
Okay, I'm provided with MR sequences of a football player who encountered a traumatic knee injury. So the first abnormality that comes to my eye is the evidence of a horizontal tear involving the posterior horn of the medial meniscus. I can see there's evidence of extensive joint effusion. And I would also like to see the cruciate ligaments again to review them, and I can see the presence of a double PCL sign, which is suggestive of a medial meniscal tear. So I would, based on these findings, I would contact the orthopedic team immediately to confer these findings and for a laparoscopic repair of this patient's knee.
Okay. Is what type of a tear is this? Bucket handle tear? Like
Yes.
is it an unstable or a stable injury?
Unstable, sir.
Unstable. And how soon should this be fixed?
I'm not so sure, sir.
Not sure. So what are the treatment options for meniscal tears?
Basically laparoscopic repair.
You mean arthroscopic? So
Yes, sorry, arthroscopic repair.
Yeah, it is a type of laparoscopy anyway.
Sorry, yes.
Yeah, arthroscopic repair. So what are the types of, I'm not getting into orthopedics mode, but just want to know what do they do with meniscal tears, basically. So if it's a radial tear or a small tear, what do they normally do?
I'm sorry, sir. I don't
No,
know the commercial
touch
content.
upon it. So that's your last case. So I'll go through all the cases that we have shown you today. So I think you did really well. You are calm and I liked your approach. So you did not come across as an anxious candidate, so which is a very good sign. And your presentation technique is very good, so you go to the observation, you have got good pauses in between whenever you need to do and you've been honest saying that I don't know this, so you can do that once in the exam, once in each VIVA, so that's absolutely fine. So yes, this is a knee MRI, and as I mentioned, it's a professional footballer, so this can be a life-changing thing. So lateral meniscus is intact, and coming to the medial meniscus, we have lost the bow tie sign, which is you should be able to see 2 or 3 bow tie sign. And as soon as you lose a bow tie sign, that means that the meniscus is torn and displaced. Okay, so in a normal meniscal tear, you don't lose the bow tie sign. So you will still have the normal meniscal volume. So as you scroll past, you can see that the posterior horn is truncated. It doesn't look like a sharp leafy triangle. And then there is a double PCL sign with a bucket handle pattern of medial meniscal tear. So this is very significant injury, because if you think of a bucket handle, it's a large amount of meniscal fragment which is torn and displaced. So if it is repaired within 6 weeks, it can go for a primary repair where they can stitch it back to the residual meniscus and hope for a good outcome. Whereas other types of meniscal injuries, they just shave the meniscus that is torn and take it out. Whereas in bucket handle tear, they need to do a primary repair because it's quite a chunky amount of volume of meniscus that is torn. So that's why it is important. Now, also on the coronal sequence, you should have only 2 structures in the intercondylar region, which is ACL and PCL. However, in this patient, you can see a displaced meniscal fragment. So you're seeing a third bit of tissue there, which should not be present. So this is a bucket handle tear. Okay, so that's about management. And the other cases that I showed you was a scimitar syndrome. So that was case number 1101. So you rightly picked up the scimitar abnormality. Again, you could have picked up COVID on this one as well. So if you look at it here, so this patient has got bilateral, bibasal, bilateral perihilar and subpleural areas of atelectasis and a bit of ground glass attenuation. So and also the clinical history of acute shortness of breath, recent onset of dry cough. So they keep showing this in television these days, isn't it? So if you've got fever, if you've got a new onset of cough, then go and get yourself tested. So this is exactly the presentation. So scimitar on its own is okay. Patient presented with COVID, and you would do a CT pulmonary angiogram and not a HRCT. So be very careful in what you recommend as the next investigation in the exam. This can be the difference between getting a very good score to a marginally lower score. Like I could have given you easily 7 on this one, but because you mentioned HRCT, which is not the right test, you could have gone to 5.5 or 6. So you got to be careful at right choice of test. So yeah, it shows scimitar and also ground glass attenuation and all the COVID's picture. So next one. So in the exam, keep COVID in the back of your mind, because the pandemic is still there. Patients are still dying. And in spite of vaccines, we are seeing a lot of deaths, and although it's less than last year, but it is still part of our normal. So in the FRCR 2B exam, if you get a case of COVID, don't be surprised. Okay, so keep that in your list of differential. And what was the other case I showed you was angiomyolipoma and tuberous sclerosis.
Yes.
So this patient, again, is it the same patient or a different patient?
Same.
It's a different patient, different tuberous sclerosis. So it was a tuberous sclerosis. The key thing is to look for any evidence of bleed, which you actually picked up quite well. The blush in the left kidney was present. And let me show you tuberous. 1107 was the 1107. That was the case. So here you can see that there is a left-sided bleed. So it's just loading, taking a bit of a time. Just give me 2 seconds. It should be fine. And you picked up the brain abnormalities quite well. So I was quite impressed with how you looked at it. So here you can see that there is a bleed. There's an active bleed. So you need to get your interventional colleagues urgently on board so that they can do embolization of this one. So genetic counseling is an important further management for tuberous sclerosis. So overall, well done. All the best.
Thank you. Thank you, sir.
So that's the end of the 3 VIVAs, I think. So I'll stop sharing screen. I hope I haven't bored you all a lot.
Not at all. That was a very interesting session, and I think this would be helpful not only for the FRCR exam, but any exam that the students may take up. So thank you for doing this, Dr. Shamsuddin. If you have any quick tips, we can go over 5 minutes.
Yeah, sure.
Yeah.
Sure. Thank you, Amar, for having me on RadioGyan. I'm a big fan of your website and you're doing a great job. And congratulations for your Aunt Minnie success as well. So in terms of FRCR VIVA, the few things I would like to suggest are, there are 3 or 4 patterns of VIVA cases. So you can prepare for a few of them, which is buy the Aunt Minnie book. So which has got Aunt Minnie cases, so you would get around 10 to 15% of those cases in the exam. So you can just go through the cases before going to bed or something like that. And also, I think most Indian candidates who are sitting the exam would have gone through either Sutton or Granger as your textbook when you read for your DMRD or MDRD or DNB exams. So what I would suggest is you don't need to read the whole book. You just have to look at the images and talk through the images. That would be a good library for you to practice the examination. And another tip I would like to give is don't panic in the exam. So people are not there to scare you, and the examiners are genuinely wanting to test how good and how safe a radiologist you are. So there is no meanness in the FRCR 2B exam. So they're not assessing, saying they are not there to fail you. So don't have that impression. The examiners are here to give us a tough time and they're there. No, actually if you are losing track in the VIVA, they are advised to guide you back into the track. So if they challenge you or if they ask you, so just take that as a clue and someone who is trying to help you rather than thinking that no, he's taking me off track. So those are the general tips I'd like to give.
Thank you, Dr. Shamsuddin, for those tips and the entire session. I understand it's a Saturday, even in the UK, and thank you for taking time on a non-working day and teaching all of us. I'm sure this is going to be super helpful for everyone. And if you meet Dr. Shamsuddin in person and would like to thank him, a little secret that I came to know is that he has a sweet tooth. So if you want to gift him something, you know what you can. So
how did you know that? Now it's gone viral.
So the secret is out. So that's if you want to give something, you can. You don't have to do anything. He's more than happy to teach everyone, but that's just a little secret.
I would be delighted from anyone who after the exam.
Yes.
Thank you.
Sure. And thank you, along with Dr. Shamsuddin, even the candidates, like Dr. Shamsuddin obviously did like a great job, but it was brave of the candidates to take up these cases. And thank you, Anil, Anish, and Jarvis for taking up the cases. It's brave to do this while others are watching you. And you all did well. The main thing, as Dr. Shamsuddin mentioned, is the approach. And you all had a great approach towards the cases. And I wish all of you, all the viewers, and even the candidates, best of luck for your exams. So thank you for taking up cases. With that, I would like to end today's session. If you've come this far, make sure you subscribe to the RadioGyan YouTube channel. We do these sessions every Saturday at 8 p.m. India time and 10:30 Eastern time. We have sessions lined up. You can check them out on our website. If you have any suggestions, do let us know in the comment section below. I'll leave a few important links in the description. If you have any feedback, you'll get a feedback email. You can let us know that, and then I'll share that with Dr. Shamsuddin. Thank you for being part of this, and we shall see you guys in the next one. Thank you. Bye-bye.
Thank you. And good luck to all the candidates. Thank you.
Thank you, sir.
Bye. Bye.
Thank you. Thank you.